Welcome to Mercy Medical Center's live webinar. Today we'll be discussing colorectal cancer, early detection, treatment, and prevention. Joining us is Dr. Dean Abramson with Gastroenterologists, PC, and Director of Endoscopy Unit at Mercy Medical Center. After his discussion, he will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Well, welcome, Dr. Abramson. Let's get started.
Thank you. So March is Colorectal Cancer Awareness Month, and the reason we're concerned about colorectal cancer is that it is the third most common form of cancer in the United States, excluding skin cancers of the skin, and the lifetime risk is 5% or 1 in 20. The lifetime risk is slightly more for men than women, 5.5 versus 5.1%, but since women's average life expectancy is several years longer, the rate of cancer for the two genders is roughly equal. It is the second leading cause of cancer death for men and women combined. So in men it's behind lung and prostate, and in women it's behind lung and breast. And while the data are not yet final for this past year, it was estimated that there were 140,000 new cases across the country, and there were nearly 50,000 deaths from colorectal cancer. In Iowa, this translates to 2,000 new cases this past year, and unfortunately, nearly 600 deaths. There are many risk factors for colorectal cancer, some that we can do something about and others that are not modifiable. It is a disease of aging, so approximately 91% of colorectal cancer is seen in individuals age 50 and older. Other non-modifiable risk factors include a previous history of colorectal cancer or precancerous polyps, or a history of chronic colitis, Crohn's colitis, or ulcerative colitis. It is a disease that can be inherited, so a family history of colorectal cancer in a first-degree relative, that means a parent, sibling, or child, puts you at risk, and that risk is more so if it was younger onset in your relatives, or if you had multiple first-degree relatives for same, and roughly we say that the risk is at least double if you've had one first-degree relative. The reasons for this are not entirely clear, as they're both genetic and environmental factors at play, but I cannot emphasize how important it is that in 75% or 3/4 of individuals with colon cancer, there is in fact no family history of same. So the absence of any family history by no means should be interpreted that you do not have a risk for developing colon cancer, because the risk is still quite high. 5 to 10% of colon cancer is definitely due to genetic mutations, and signs that you may be at risk for this would be multiple relatives with onset of either colon cancer or ovarian or uterine cancer at age 60 or younger, or a strong family history of precancerous polyps occurring at a younger age. And there are probably two main syndromes that explain this. One is called Lynch syndrome, or hereditary non-polyposis colorectal cancer, which was put on the map by Professor Henry Lynch, who practiced in Nebraska. And this condition puts you at an 80% lifetime risk for colon cancer. Another somewhat rarer but longer known syndrome, familial adenomatous polyposis, carries with it a risk of 100% for developing colon cancer in your lifetime, and as such is an indication for surgical removal of the colon at an early age. Colon cancer favors certain races over others and certain ethnicities. African Americans, it is known, have the highest incidence of colon cancer in our country. and this is 20%. Interestingly, this is not seen so much in Africans. African Americans also have the highest mortality of any racial group, 45%, and this is thought largely due to later stage of diagnosis and poor access to quality health care. Asian Americans, Latinos, Native Americans have a lower risk for colorectal cancer, and white Americans, Caucasians, are somewhere in between. The risk for African Americans, in fact, is high enough that some have advocated testing at an earlier age, but unfortunately the insurance industry has not seemed to accept this recommendation as yet. Certain ethnic groups are at higher risk, and actually Eastern European Jews or Ashkenazi Jews have the highest risk of any Caucasian ethnic group due to a recently diagnosed unique mutation in that ethnic group. There are risk factors that we can do something about, however, and dietary risk factors, red meat, processed meats, and meats that have been cooked at extremely high temperatures are carcinogenic and favor the development of colon cancer. A diet that's rich in vegetables and fruit and whole grains may actually decrease the risk for colorectal cancer. Exercise is also associated with a decreased risk of colorectal cancer compared to a sedentary lifestyle. So even moderate levels of exercise can be protective. Alcohol plays a role in the development of colorectal cancer. So more than 2 drinks a day for men or 1 drink for women may place you at increased risk for colorectal cancer. Adult metabolic syndrome is something that we're seeing in epidemic numbers these days, and this is the combination of obesity, type 2 diabetes, high blood pressure, and high cholesterol. And this can increase the risk for colon cancer and the development of precancerous polyps by up to 50%. And in terms of obesity, we're talking about a BMI of 27, greater than 27, and central adiposity, or the pear shape, is more critical in this regard than the total weight, and that's also seen as a risk for heart disease. We don't really think about it much, but colorectal cancer is also a disease of tobaccoism. It is a tobacco-related malignancy, and for people who started smoking at a young age, particularly age 18 or younger, this can put you at a risk equal to having a first-degree relative with colorectal cancer. And when they've looked at when this risk is decreased, it may take 20 years following smoking cessation to return to a normal risk group for colon cancer. So what are the signs and symptoms of colorectal cancer? What should we all be looking for? Certainly persistent rectal bleeding, or a change in the bowel habits, either a change in the size or shape or color that is persistent, may be an indication of colorectal cancer. Similarly, persistent abdominal pain or cramping, or weight loss that is unintentional and not explained by any other factors. All of these may indicate the development of colorectal cancer, but I cannot emphasize enough that early stage colon cancer typically is clinically silent, meaning that there may be no signs or symptoms. So the absence of any of these findings does not mean that we are not actually harboring a colon cancer. And similarly, when we investigate for any of these signs or symptoms, we may not find colorectal cancer, but another explanation. Nevertheless, you should not ignore these signs if they're persistent. So what can we do to try to prevent colorectal cancer? Certainly, we can change our lifestyle, as I mentioned, in terms of dietary changes and increased exercise. People have looked at pills that we could take in terms of chemoprevention. And some of the things that have been looked at are aspirin, ibuprofen, drugs like Celebrex, and these are the non-steroidal anti-inflammatories. Unfortunately, the benefit was little, and the risks potentially were significant for side effects. So we don't necessarily recommend doing this, but if your cardiologist believes that you should be on an aspirin a day, you may be benefiting not only the heart but the colon. Hormone replacement therapy was looked at in women, and this is not recommended as a colon cancer prevention because the risks outweighed the benefit. Calcium supplementation has been extensively studied, and the benefits are quite modest, but they are in fact present. Fiber supplementation was looked at and could not distinguish any benefit from this compared to placebo. So for colon cancer, the best prevention of all is screening. And early detection of colorectal cancer makes a major difference in survival. So if you have early stage disease, the 5-year survival is 90%. Once it's spread to the lymph nodes, the 5-year survival drops down to 68%. And if it's spread to other organs like the liver or the lungs, the 5-year survival drops dramatically down to 11%. In our state, 43% of colorectal cancer is diagnosed at early stage, so less than half, unfortunately. And it's estimated that 30% of the deaths from colorectal cancer over the past quarter century could have been prevented by early detection. And by early detection, we're really talking about the removal of precursor lesions. Colorectal cancer is fairly unique amongst the types of cancer in that almost all colorectal cancer begins as a precancerous polyp, and there really is nothing analogous for this in prostate, lung, or breast. So it offers us a unique opportunity for intervention and prevention. So when we're talking about polyps, what we're talking about is something called an adenoma. That's the precancerous polyp. And adenomas represent roughly half or more of all colon polyps. So typically when we're doing screening examinations in people age 50 and older, we find precancerous polyps in roughly 25% of men and 15% of women. So they are a common finding. The good news is that adenomatous polyps are very slow growing, so typically it takes 5 to 10 years for a little polyp to become a colon cancer, and it offers us quite a long period of time for intervention to decrease the risk. There are a variety of ways of screening. I think everybody's familiar with the stool cards that doctors will give you to detect microscopic traces of blood in the stool that you otherwise cannot see. Unfortunately, these tests are far more sensitive for detecting cancer than precancerous polyps, so they're not terribly useful, but certainly a positive test would mandate a more rigorous screening strategy such as colonoscopy. There was an exam called a flexible sigmoidoscopy that was popular 20 years or so ago, and typically everyone age 50 would get a sigmoidoscopy every 5 years. This was a short scope that examined the lower third of the colon, but unfortunately it was largely abandoned because it would detect less than half of precancerous and cancerous lesions. Similarly, people may remember a barium X-ray of the colon, which was quite uncomfortable and cumbersome to perform, and it had limited value. A new test that's been on the horizon now for quite a while is a so-called virtual colonoscopy. And what this is a specialized CAT scan X-ray of the colon that can be used to not only detect colon cancer but colon polyps. It's still somewhat in the developmental stage and is not covered by insurance yet as a routine screen, but increasingly it may become an option. The problem with all of these screening tests is that a positive result mandates a colonoscopy, and a negative result is not an insurance that you don't have a lesion. So colonoscopy, for a variety of reasons, now accounts for 80% of all screening tests done in this country for colorectal cancer. And the beauty of colonoscopy is that it detects and removes lesions. It's the only screening strategy that can remove lesions as well as detect them. And it does so with a high degree of sensitivity, specificity, and a low risk for complications. Complications of colonoscopy occur in 1 or 2 out of 1,000 individuals undergoing the examination, and these can include serious complications such as perforation or bleeding, particularly if a polyp is removed. A well-done colonoscopy offers the potential for a 10-year clearing, meaning if you're in an average risk group and you have a negative examination for precancerous polyps, you may go up to 10 years before your next screening examination. It has been estimated that colonoscopy may prevent up to 12,000 deaths from colorectal cancer a year. There was a landmark national polyp study that was published in 1993, and much of our data for colorectal cancer prevention stems from this study. It involved 14 academic centers throughout the country that enrolled patients to undergo colonoscopy. And there have been data that have been coming out of this study on a regular basis ever since. So it estimated that 76 to 90% mortality reduction from individuals who underwent a single colonoscopy for screening purposes. And when it was initially published, based on data from 1980 to 1990, this benefit persisted for 10 years. Interestingly, since 1986, with the widespread adoption of screening colonoscopy, mortality from colorectal cancer has dropped 1.6% a year. And it's estimated that up to 22,000 deaths from colorectal cancer per year now arise from individuals who did not, unfortunately, avail themselves of screening colonoscopy. Just last month, another study was published out of the original patients who underwent the National Polyp Study. And this followed the same individuals from 1980 to 1990 who underwent colonoscopy and were found to have precancerous polyps, and these individuals subsequently underwent routine colonoscopies for follow-up at less than 10-year intervals. And what it found in this group was that there was a 53% reduction in mortality from colon cancer compared to control groups. And this has been felt to be the most convincing data yet of the health benefits of colonoscopy. So who should be screened or who should undergo colonoscopy? Average risk individuals should begin colonoscopy at age 50. So these are individuals who do not have a family history of colon cancer and do not have any signs or symptoms of disease. And if the exam is negative, they may go 10 years before their next examination, assuming that their family history remains negative for colon cancer. If you have a first-degree relative, so again, a parent, sibling, or child who has had colon cancer or a precancerous polyp occurring before age 60, screening should begin at age 40 rather than age 50. And certainly if that lesion was diagnosed at a very young age, say age 35, then you should begin 10 years before that. If your relative was age 60 or less, then we recommend exams every 5 years rather than every 10, even if the exam was negative. If, however, your relative had colon cancer, was older than age 60, we do the first exam at age 40, but then we drop back to a 10-year interval thereafter because the risk is not felt to be much greater than the average population. And there are special guidelines for people who have a genetic disorder such as familial polyposis or Lynch syndrome, and those individuals begin in life much earlier, even before they hit age 20 sometimes. And there are special guidelines for people with chronic inflammatory bowel disease as well. So how can colorectal cancer be treated once it's found? If it is extremely early stage, occurring in a raised lesion or polyp, simply removing the lesion with colonoscopy oftentimes may be adequate and surgery may not be necessary. If, however, as most colorectal cancers are larger, they do require surgical resection, and there have been advances now in surgical techniques involving laparoscopic and robotic assistance that enable less invasive procedures and enable surgical resections much closer to the anus than before. There have been dramatic advances in adjuvant therapy with chemotherapy and radiation as well, which have resulted in a marked reduction in mortality over the past 20 to 30 years. So dramatic advances. There is a team approach here, so this may involve a gastroenterologist, a surgeon, a medical oncologist, and a radiation oncologist, but more and more even advanced colorectal cancer has become a treatable disease where people can have many years of quality life as a result. What is the outlook for colorectal cancer today? There's a lot of good news here. Through expanded screening as well as better modalities for treatment, the mortality for colorectal cancer is dramatically declining. So it's declining by nearly 4% a year for men and 3.5% for women. In fact, the National Cancer Institute predicts that mortality from this disease could fall by as much as 20%, rather 50% by the year 2020. However, the bad news from National Institutes of Health data suggests that still 45% of Americans age 50 and older are not availing themselves of appropriate screening modalities. So for more information on colorectal cancer and colorectal cancer screening, you can access our website, and to view a live colonoscopy performed at Mercy Medical Center, you can visit Mercy's Medical Center website as well.
Oh, thank you, Dr. Abramson. To remind you, your questions can be submitted from the box in the upper right-hand corner of your screen. We'll get to the first question. That's an obvious one here, I guess. Why do we need to drink all those laxatives before the procedure?
Well, unfortunately, probably the worst part of this examination for everyone concerned is the prep that precedes it. We really need a pristine prep where there is no adherent stool or mucus remaining so that we can detect lesions in the colon. And in fact, in recent years, there is a changing tumor biology where more polyps are becoming very subtle and flat and hard to see. And if there's retained stool or mucus in the colon, these can easily be missed and account for interval cancers after a screening examination. So the larger volume purges are safer. They do not contain ingredients that can be toxic to the kidneys, for example, and are well tolerated even by the elderly without results in fluid shifts or electrolyte shifts or congestive heart failure. It's actually a rare individual who will get an excellent quality prep out of a so-called mini prep, which involves a small bottle or a few pills. So unfortunately, going back to the National Polyp Study, that was based on a 4-liter or 1-gallon prep, and those were also based on leading clinicians or academicians performing colonoscopy to extrapolate that data to a community setting and to physicians who are less well trained and now using many preps. I don't think that we can guarantee anyone that they can have a 10-year disease-free interval after a screening examination without an adequate prep. And I think that any provider who can tell you that he can do so is being less than honest. So I cannot emphasize enough the importance of a thorough prep to a good examination and peace of mind, as well as good health.
We have a couple questions about age. The first one, I am a 76-year-old male, will be 77 in May, had a colonoscopy in 2005 that was negative. There were no polyps, but a slight diverticulitis. Do I need to have another one? And we have another question, someone asking about a mother who was 81 years old. Does she need a colonoscopy at that age, and hers without any anything of risk?
So in terms of who should have a so-called screening examination, the official recommendations are to begin at age 50 and to offer the last so-called screen at age 75. And the rationale for this is that we're talking about a 10-year disease-free interval after the examination. So obviously, if you are 76, then the question is, do you anticipate good health at age 86? And if so, you should have another examination. So we'd all like to think we're going to have good health for a good long time, and it becomes a judgment call. By no means should we think that the procedure itself is more risky in the elderly. The risks are actually the same, assuming that you're otherwise in good health with good heart and good lungs and not advanced medical problems. So it becomes a matter of the benefit. And I think if people are in excellent health and they're age 76 or age 77, having another examination is reasonable. Medicare will pay for it. So it really becomes a judgment. Certainly what we don't want to be doing is examinations on people in their upper 70s or early 80s who are in poor health or not likely to get the benefit from this exam. So it becomes a judgment, and it should be entertained after a thorough discussion with your personal physician.
Okay, a question about, are there any new medications to prevent polyps? In the past, aspirin and other medications have been used.
Okay. I did have a slide that did address this. There is a modest protective benefit from low-dose aspirin. A lot of the COX-2 inhibitors have been removed from the market because of cardiovascular risk. The benefits are modest from low-dose aspirin, and certainly if there's another reason for an individual to be on low-dose aspirin for heart or stroke prophylaxis, then I would view it as another added benefit. But overall, the protection afforded by low-dose aspirin is quite modest. Calcium in 1.2 grams a day is something that also confers a modest benefit, and it may well be worth taking, especially if bone mineral density loss is a concern for the individual.
We have another question about a mother who is 81 and in good health, had an exam in early 2000. Should she be screened again? She has trouble with constipation and uses laxatives regularly, but does not have a diet that is very high in fiber. Anything specific about this case?
Well, again, in general terms, if one is 81 and has been in excellent health, and not on many medications, having another examination may be reasonable. Constipation itself is not a risk factor for colon cancer. Diverticulosis is not a risk factor for colon cancer. So it becomes a judgment, and I would certainly not be adverse to a healthy 81-year-old going through another exam if it's been 11 or 12 years since the last one. I think it can be a reasonable thing to do. But again, it should be individualized, and probably should discuss it with the primary care provider first.
Very good. Changing the subject a bit here, is my doctor's referral necessary to schedule a colonoscopy?
It is not entirely necessary, no. One can visit our website and arrange for a screening examination.
Next question, will my insurance cover a routine screening colonoscopy?
That, unfortunately, has become a bit of a moving target. One of the benefits of health insurance reform that we've seen in the past few years now is that more and more insurance companies are covering screening examinations because they've been mandated to do so. And in fact, to do so without needing to meet the usual deductibles. So it can be an entirely free exam. The downside of this is games that the insurance industry is playing now to label something as other than a screen. So to truly have a screening examination, one must be in the appropriate age group, so age 50 or older, and not have any symptoms. So if someone has occasional rectal bleeding, which many individuals have had on a rare basis, the insurance company may construe that to be a symptom and immediately eliminate that as a screening examination, such that now you have to pay a deductible and a copay for the exam. And increasingly, the language that the insurance industry is using is that if this is a prevention, it will be covered, and if it's a diagnostic, it will be covered to a lesser extent. But in fact, there's no way to code these exams in terms of prevention or diagnostic. There's only one code, and the insurance industry is well aware of that. They're simply looking to try to avoid allowing the maximal payment. Another trick that some insurance companies are using is if we find a precancerous polyp and remove it, all of a sudden they're no longer calling it a screen, and all of a sudden unfortunately, the patient is subject to a deductible and a copay. So this is a moving target. Every insurance is different, but it is becoming an increasing frustration as the insurance industry seeks to not live up to their obligations.
I believe we have covered all the questions that have been submitted us so far. We'll wait a couple minutes yet, but if you have additional concerns or questions, be sure and check the website for contact information. And again, to remind you to view the webcast of the actual colonoscopy that Dr. Abramson mentioned, go to either the Mercy's home screen, which is mercycare.org, and follow the link, or you can go directly to the link that you see on your screen, /live colonoscopy, and you'll be able to get the inside close-up view of that procedure. Now, a tape of this program will be available at the Mercy website, mercycare.org /live in just a few days. And you can always check this website for information about future webinars as well as past webinars. Our next webinar is titled Walk Your Way to a Healthier Life with Kayla Sodawasser, a Health and Fitness Coordinator at Mercy Fitness Center. The webinar will be held Thursday, April 12th at noon to 1, and again, she will be available to take your questions after the discussion. I'm going to check. I don't see additional questions, so I believe that concludes our webinar, and thank you all for joining us today.